Thanks, Elizabeth. I'm Amy Yaroch, Executive Director at the Gretchen Swanson Center for Nutrition, which is a nonprofit nutrition. Up a little more.
Okay, let's see if that's better.
Is that better? All right. Gretchen Swanson Center for Nutrition, which is a nonprofit nutrition research center headquartered in Omaha, Nebraska, but we went all remote. So now we are 55 people across 26 states. And it's funny, when Elizabeth said this was going to be like an Oprah-style sort of thing, I thought, do I get to say, and you get a car, you get a car, you get a car? But I don't, so I was kind of sad about that. And one other thing I was going to mention is that for those of you who are interested in going to an international nutrition research conference, how many people have an interest in that with Kofi Essel? Kofi Essel as the keynote? Because it's going to be in Omaha, Nebraska. It is an international conference, but it's the International Society of Behavioral Nutrition and Physical Activity, and it'll be in Omaha, Nebraska, May 20th to 23rd. And I'm co-hosting it, hence why I'm doing the plug. But since Kansas is not very far, I'm actually going to be driving to Omaha tomorrow. So it's a drive away. Highly recommend it. So I'm going to have the panelists all introduce themselves, and with that, name, title, affiliation, what you do day to day as it relates to food as medicine, and then I will be asking some questions. So.
Great. Well, thank you so much for being here. And that last panel was so fantastic. I'm looking forward to this conversation. My name's Kim Prendergast. I'm the Vice President of Policy for Community Care Cooperative. We are a federally qualified health center-led accountable care organization. So most of my perspective today will be about our food as medicine work with the 1115 Medicaid waiver in Massachusetts. But just to share a little of my background, I'm from Indiana originally, so I have some rural roots, and spent about 20 years working at Feeding America, so know food banks well, have really thought a lot about ways in which food banks can be partners with the healthcare sector and the work I was doing there. And I bring that lens to the work that I do in Massachusetts. And being a state that has a Medicaid 1115 waiver and recognizing the great opportunity that we have when we have dollars to put all of our good ideas to use, I also recognize that we have some responsibility to share those learnings. And so we've really been thinking about what's working in Massachusetts because it's Massachusetts, and what are the types of aspects of our partnership that are working that will work in other places. So hopefully we can share some of that today.
Hi, I'm Elizabeth Keever. I'm the Chief Development Officer at Heartland Community Health Center. I've been with the FQHC in Lawrence for about a year and a half, and in my role I oversee our grant and fund development, marketing communications, and some of our public partnerships with other organizations in the community. But one really kind of interesting thing that brings me to this seat particularly is that before I switched over to Heartland Community Health Center, I ran the area food bank. Its name is Just Food. I think we'll meet some of those folks tomorrow, actually. And Just Food is a redistribution organization of a larger food bank in Kansas City, and it served around 20,000 unique individuals. And I was the executive director for 7 years and with that organization for 9 years. So have an interesting relationship with how those two systems bridge the gap. And Heartland also has a food pantry on site that is a satellite of the Just Food food pantry. So really still have that strong relationship with that entity and how those worlds intersect.
Great. I sense a theme going on over here, knowing some of these people. So my name is Melanie McGuire. I am the Senior Director of Programs at the Houston Food Bank. And I have been in food banking for 13 years. I had an opportunity to start my work in New Orleans and was the Chief Program Officer in New Orleans, covering all the way to the Texas border, then moved into San Antonio and now in Houston. And my work really centers at the Houston Food Bank around what we call our Food for Change initiative, which is our intervention strategy specifically targeting in 3 key domains to address poverty, which is community health, economic mobility, and education. So we make strategic investments using food, working with communities in those 3 areas. So happy to be here today.
Hello, can you guys hear me all right? My name is Davna Gould. I am the Chief Marketing and Communications Officer at HealthCore Clinic. We are an FQHC located in Wichita, Kansas. Let's see, I've been with the organization for about 12 years now, and under my scope, I have a lot of the outreach prevention programs, and so I get the exciting job of taking all this patient data and figuring out how we can provide services and wrap additional supportive services around our patients that present at our clinic.
Great, thank you all. So my first question is going to be for Davna and Elizabeth. So what are the strengths and limitations of using the healthcare provider as the nuclear nexus for food as medicine interventions?
All right, I'll get started. I think for a healthcare provider to have a whole bunch of tools in their tool belt to be able to address all of these social drivers of health that our patients show up with. So a lot of times when patients show up, we just have to meet them where they are. They have a lot of things in their lives, a lot of barriers that prevent them from accessing, first of all, healthcare. So if we can get them there, that's number one. And then as they assess in the exam rooms and do these screening tools, we've developed these programs to address it. So they come into our facility and we can kind of stabilize them, and they can leave in a better place than what they were when they presented. So at HealthCore, we have a healthy food pantry that's open to all of the patients. We have community health workers embedded in different locations to help with housing, transportation, even signing up for insurance. So it makes sense because when our patients get here, we can address some of those health concerns, but we all know that there's more than just those health concerns that affect our patients, and so I think that's the important piece.
And we're in a very similar situation in the sense that when we're working with our patients, especially through the Food as Medicine program, the individuals who worked with more and more integration, those who went through our chronic care management program with their provider, worked with a community health worker, attended those cooking classes. The more you engaged, the better your outcomes were. So, but that being said, when it comes to being the sole responsibility of making that change, we really relied on our partners to be able to do the work that we do. From a feasibility standpoint, we didn't have a budget to sustain this sort of food intervention. So our community partners were really key on that, but also provided some, and I know we'll get into it, so I won't, go too deep into the weeds, but, there's a lot of limitations on the accessibility of healthy foods and the charitable food system. And so it created challenges, but opportunities to learn from one another. So, going at it alone is definitely not the recommended from my vantage point on how to proceed, but really looking through strategies on how to build both systems and entities up.
Great, thank you.
Amy, can I add one thing to that?
Oh, yeah,
Just to share. So my organization is a health center-led accountable care organization. So we're running the Food as Medicine programs, adding that additional level of sort of administration to the work. But it's really the providers that are making the referrals into our programs, with the added benefit of having some dollars to pay the bills. But I think what's been so beneficial from that provider perspective, especially looking at some of our counterparts in Massachusetts that take a different approach, 93% of the members who were referred into the programs successfully connect with those resources. And we worry a lot about what about the 7%? And the social service organizations have someone at the provider that they can reach out to. You sent me this referral and I didn't connect. This phone number is not accurate anymore. And making those connections, the community health workers in particular, making the referrals, say, I trust that when I make that referral, I know that something that the social service organization will be able to support this member. We can set those expectations, and now we can move on to their other needs. And it creates a trust, and it really creates a lot of I think, job satisfaction for providers as well. And in a phase where workforce is so challenging, not just asking providers to ask these questions about screening, but equipping them to be able to do that work is really valuable too.
Great, thanks. And Melanie, so I feel like people sometimes get confused between food banks and food pantries. So could you tell us how they differ and also how they differ in their roles in food as medicine?
I'm glad you asked that question. I hear that quite often. Yeah, I think obviously the food bank, as Kim mentioned, we are part of a national organization, Feeding America. There are over 200 food banks across the country. Every city is connected to a food bank. And then the food pantries are really the place-based locations in which people can directly access food. I will say that food banks are changing, right? And so a lot of this research that we're learning is really help shape, what are the strategies we need to be employing moving forward. And, place-based services, as we understand, are critical to addressing these needs. In fact, we look at studies with our food prescription programs, and we see higher utilization rates when we have a place-based setting embedded. So it's great to hear clinics and healthcare providers that are making investments right now, in many cases where those dollars are not coming from up top, into things like integrated food strategies within their clinical setting. Because what we're seeing is where we can have those place-based approaches is the areas where we're seeing high success. I think the other thing to note around just food banks in general, COVID certainly exacerbated the need and highlighted a lot of the areas around food insecurity, although we know that this has been a prevalent issue within our communities, and food insecurity isn't just about food, right? And so, as Kim mentioned, getting to those kind of root cause areas is critically important, and programs that support root cause issues are important. We talk about our work in kind of two settings: feeding the line, which is primarily what people understand about the food bank network, right? Is the lines of people lining up to get food, right? But we are increasingly making more investments around shortening the line approaches, right? So what are we doing to actually ensure that we're using this, this resource in partnership with other strategies to make sure that we're really building trust in communities, that we're thinking about some of those disparities where we're seeing those high levels of disparities, and working together to address those issues.
Great. And then this is for anyone. So how can we design effective food as medicine interventions without the direct healthcare provider? So for instance, an insurance company identifying patients that qualify, referring them to a third-party service, and then cutting out the middleman, of the provider or the clinic.
So I think I need to stew on that one a little bit more, but I think that one thing that I want to add to that idea, and kind of bouncing off of what you just said, that a lot of food insecurity has nothing to do with food insecurity. When you look at the average food bank strategic plan compared to the answers that you get from beneficiaries of food banks of what would solve your food insecurity, you've got two completely different lists. And there was a 2021 study that was done, and it looked at what beneficiaries said. And number one was more money to pay bills. Number two was better access to quality food, just fruits and vegetables, transportation, financial literacy. And number five was support families' mental and physical health. So when you look at those barriers, those identified key strategies from the voices of the beneficiaries of the charitable food system, the role of healthcare plays a role into that. Mm-hmm. And it's incredibly significant. And, as we saw a lot of the organizations who were participating in the Food as Medicine program, it was the wraparound social determinants of health addressing a multi-pronged approach to food insecurity. So doing work in silos and omitting healthcare from the conversation is not going to lend the results that I think you would want, from the investment.
Are there ever too many cooks in the kitchen, though? Do you ever feel like we want to have the right sectors there, but are there, other sectors that should be included or other sectors that should be taken away?
I think when it comes to there being too many cooks in the kitchen, to me, it's more about advancing the work of those who have a vested interest. I mean, for example, food banks could not prioritize this population, but 32% of food bank beneficiaries have type 2 diabetes. Mm-hmm. So, no matter what, they're interconnected. So one's impact is going to impact the other. So it's better for there to be collaboration than silos, in my personal opinion.
Mm-hmm. Anyone else?
Sure. I'm always going to advocate for the provider at the table and driving food as medicine interventions because, and I think this was kind of where we ended with the last conversation, we want to make sure that we're thinking about what is it the members need, the patients need, and how we're really assuring that our food as medicine programs directly respond to the clinical care needs of patients. And so when we're thinking about diabetes care for an individual who's food insecure, making sure that the provider and the care team know how it is that their patients are getting better food security access is vital to being able to provide that care. That said, I don't think we need everybody at the table, and certainly our friends who are the payers, and my role, we're sort of a payer provider, which means that we've been able to really leverage the health centers to do that work and then pay the bills on their behalf, which means that they're not doing the administration of it. But not everyone is seeing providers. Right now, we have a huge workforce shortage in the healthcare sector, and a new patient to our health, to Mass Health in Massachusetts would be hard pressed to get in to see a provider in the next, couple of months. So if there are scenarios through which the payers, health insurance companies and plans can also be providing supports in ways that are meaningful, that's fantastic. So I think, to the point that all of us can be, there's room for everyone to be able to address the financing issues of this in particular.
And I would just add, I think maybe the question needs to be, how do we build bridges to these conversations, right? Because one of the dangers and one of the things I see with community-based organizations and the clinical setting is we really don't have a way to speak to one another, right? And so oftentimes, in even some of these pilot programs, community-based organizations are spending an inordinate amount of money on technology, which really is problematic as we think about scale and scope of this work moving forward. And really, ultimately, from a community-based perspective, the idea is for most of that funds to go to the actual people that we're serving. And so I think what we've been doing specifically in Texas, and we've been doing for over 10 years, is just how do we build bridges? Because we're not going to have one system approach, right? It's how do we build bridges that we understand how these intervention strategies are playing out in communities, right? And so there has to be a role for everyone at that table, and that insight needs to be shared. I love the comment around, how are you building with community, not for community? And one of the things is we have a joint committee of community members that has just as much stake at the table than we do as paid staff. And that is intentional, so that we don't get into these silo kind of thinking models where we're forgetting, the core of who this is impacting at the end of the day. So I think the investment strategies and funders who can help build those bridges, because from a community-based perspective, we see lots of barriers in terms of how we share data, right? I don't need to know patient A's A1C, but I do need to know how is this investment of food or social services impacting that setting and that particular person.
So it's, building bridges, but also breaking down what I heard referred to one time as cylinders of excellence or silos.
Absolutely.
Yeah. Okay. So this one is for anyone who wants to answer it. So what do you wish the person not working in healthcare or charitable foods better understood about your job, especially as it pertains to the potential of food as medicine becoming more mainstream?
I can hop right in. So maybe not about my role right now, but I think a lot of people don't really fully understand the volume in which food banks receive food. 60% of all food from food banks are from donations, 23% are from federal, food programs like TFAP or commodities, and 19% are just purchased. So it makes a really big challenge when you're looking at how to prioritize healthy product when you have a large volume of inventory that you can't manage. And really, when you look at systems approach of, behavioral economic strategies, I mean, we all know display fruits and vegetables in a appealing way, and that results in people taking more fruits and vegetables. Well, unfortunately, when you go upstream on the charitable food system, so much of that product is not managed by the food bank themselves unless they have really, strict limitations on the nutritional value of the product that they take in. And, it makes it a challenge because also food banks really struggle with space. And this is going to be an unpopular thing to say, but I opened up our local food bank ordering system, and the first product that was all free was bulk donut mix, tonic water, garlic cheddar biscuits, cake mix, all for $0. And then you get to the first items that you see that are purchased, applesauce, dried beans, and then the very first vegetables, which is 19 items down, is a can of corn. And that costs the food bank 52 cents a can, or food pantry 52 cents a can. But that box of macaroni and cheese is only 36 cents a box for that food pantry. So, and those prices are different than the balance at a grocery store. If you go to Walmart right now, that box of macaroni and cheese is about $1.19, and then that can of corn is about 50 cents. So you've got the priorities because of the balance of, it costs a partner agency $0 to get donut mix. Well, when you have $1 to spend, how do you prioritize it? And I think that's a really big challenge that a lot of agencies that work within the charitable food system is no one wants to throw away food, everyone wants to maximize the dollar, but we don't have upstream, behavioral economic strategies that prioritize healthy eating in a lot of ways. And I'm so excited about some of the work that the Houston Food Bank is doing that is changing that. And not all food agencies charge, so you'll talk about that. But I think that's something that I really wish people understood, especially when it comes to donated product.
Anyone else want to answer that question first?
Sure, yeah. Hot seat being the food banker, isn't it?
Sorry.
No, you're good, you're good. No, absolutely. I think, one of the things that we did in Houston was we eliminated fees many, many years ago. And so, a shared maintenance fee, for those of you who may not understand what that means, is there's a fee attached to products that many of our food pantries access. And there is an opportunity for certainly more fresh produce in that mix, right? I think working with local growers and that space is incredibly important as we think about the foods that are being donated. Interestingly enough, the foods being donated come very much from retail settings. So on the one hand, I'm like, well, it's not selling in the stores, right? And so we had the same conversation many, many years ago about soda and a lot of food banks kind of have eliminated that from their offerings. I think the thing I would most encourage us to think is, I think, there's not going to be one strategy. And certainly I think as we think through what it will take in this food and medicine space, I think we all have to be really thinking outside the box. Some of the strongest nutrition assistance programs right now don't come from food. They come from our federal benefit programs such as SNAP, right? SNAP, $1 investment in SNAP provides 9 meals. But we don't screen people for SNAP in a clinical setting. Maybe that's something we need to be thinking about. And so I think, it's critically important that when we think about these interventions, I think the most important thing is we need to start the conversation, right? And in some cases, that's not always easy. Having these conversations is difficult to think about, what responsibility do we all have in communities to ensure that we're providing the most nutritious food, and what is the impact, both the qualitative and quantitative impact that it's having in communities. So I would just encourage that dialogue. I think It's important to have lots of perspectives in this space and lots of people at the table. And I will tell you, from a community-based organization perspective, we have a motto at the Houston Food Bank that we study 1% of everything we do. That's kind of our litmus. How we measure that is funny math, so don't ask. but it's with that intentionality, because I think we are interested in what should we be thinking about moving forward. And the face of food banks are changing. If you look at the food banks that are putting in a lot of resources now in Tampa and Ohio, we're doing in Houston, even the space is changing. So food banks are thinking less about the storage of food, right? And just how do we making sure that we're bringing everyone to the table? So you'll see lots of co-locations of community-based organizations all working together. The Tampa model actually has it almost looks like a mall, what it's gonna look like, right? But it'll be all community-based organizations. So we really have to play on our strengths and work together in this model. So that would just be what I would encourage.
Mm-hmm. I would say from our perspective, having a relationship with the food bank has been really positive. I don't hesitate to ask for things that I feel like we need, and while I know that it takes them longer to procure them or figure out how to get them, they have delivered on some pretty important things that supported our program. Unfortunately, the length of the product being available wasn't the full term of the pilot. And so I think the food bank is struggling with that push, and I believe it's coming, but as we've learned today that, systems don't always align at the same time. And so for us, I think it's strengthening those partnerships and knowing when to go somewhere else and say, you know what, this isn't quite the best fit for our patients, and so we need to forge a relationship in other places and see how we can supplement and really make sure that our patients are getting the freshest, healthiest fruits and vegetables or programs, or we just have to go beyond those relationships we've forged and we're comfortable with, and really not fight, but really make sure that we're putting our patients' needs up front. So working together, I think there's a place for everyone at the table. I think taking healthcare providers out of the equation is completely the wrong way to do it. When we talked about having many chefs in the kitchen, I think more chefs are fine. It's just sometimes you need to be a sous chef and sometimes you need to lead. So thinking of it that everybody is welcome at the table, everybody has great input, but sometimes I'm just prepping things for someone else to shine.
I have three quick things that I want people to know on that front. One, food banks are phenomenal and play such an important role in addressing food insecurity, but we can't think that the healthcare sector can screen and then refer to the charitable sector and see improvements in health outcomes. So as healthcare providers, as the healthcare sector, we have to invest in the response that we're providing and making sure that the food banks aren't having to grant fund to support our health outcomes. So that's my first point. With that, CMS, Medicare, and Medicaid are interested in supporting this. In November of 2023, CMS put out guidance for the state Medicaid agencies on what you can ask for with 1115 waivers. So they are just asking states to apply to be able to leverage Medicaid dollars for this purpose. And so most of the folks in this room, I think, are in states that don't have 1115 waivers, and big opportunity to leverage dollars to make that happen. And when that happens, this is my third point, I promise, we can then reinvest in the community. And what's been able to be possible in Massachusetts is, and I think about, what are the lessons that are transferable to rural communities? We've spent $20 million over the last 4 years supporting goods and services for our members, which means we've hired dozens and dozens of people who work at social service organizations. We've invested lots of money in the local economies, and in rural communities, that's transformational. So drawing down those dollars from the federal government and being able to reinvest and have improvements in health outcomes is really amazing across the board.
I want to throw one more thing in there. So when we think about our patient population, we have a 30% uninsured rate. So while it would be great to be able to bill for services for all of our patients, there is still that large population that we're not going to treat them any different when they come into our doors. They're going to have access to every program, regardless of their insurance status. But as an entity, to be sustainable, we have to also keep that in the forefront of our minds.
Great. Melanie, I feel like Elizabeth mentioned about your innovative programming that you're doing, so I'm really curious if you could tell us more about some of the innovative programming at Houston Food Bank.
Yeah, sure. So as I mentioned, our organization has a commitment. Right now, about 20% of our organization's output goes toward innovation strategies in these key areas of health, education, and economic mobility. And what that means in practice is that we're strategically working with organizations who have these outcomes in mind, right? So whether it's investment in job training programs that help people obtain higher paid employment, or whether it is working in community-based health settings. And we've been doing this for the past 10 years. And so what that looks like in practice is, in many cases, we are providing a lot of the capacity needs for these entities to have these place-based approaches, where and if that can't be possible, particularly in rural communities where it may be difficult to embed, a food strategy, but there's certainly a need for that. We've brought resources and equipment to allow for those spaces. We leverage community assets based on what our communities are telling us is valued in the community. So we work with quite a numerous schools and communities. And the fun thing about these programs is that we're not running them, right? So it's really the community's program. Our school-based programs are run by students. The students run their own markets, and they can tell you the value of the foods and vegetables that they're receiving. And so what we've noticed, is that there's really a high level of interest in this work. One of our healthcare systems has not only just talked about some of the quantitative and very, very similar to some of the data that was presented. So that's reassuring that our data, there's some patterns there between states, but also just the qualitative part of this work. What it means to actually be able to provide someone, whether it's fruit or vegetables or a nutrition class in that setting, and how it's improved their patient engagement. And I think those quality measures of engagement could not be amplified more, and we have to do way more of that amplification of how these programs are really having an impact in people's lives, because I think that's the stuff that we hear at the end of the day.
And if you were going to get some outside help from any other sector, who would it be and what would it be for?
Well, Kim knows I lean on her a lot. But, I think, we recognize our strengths, and our strength is certainly there's a high level of trust between community-based organizations and communities in many regards. But, we don't have the expertise on the research and analysis side. We work with organizations to understand how policy implications can support organizations and communities, and not just the food bank, but communities as a whole. So I really think that space is incredibly important. We understand that there's so many threads that tie to advocacy, and so that is this area that we lean heavily on, and that we don't try to build that within our organization. We really work with other organizations that have that expertise.
Great. I think I want to turn it over to you all if you have any questions, because I think we're running out of time.
You're perfect. We got 5 to 8 minutes for questions.
Chris?
Oh my gosh, y'all are awesome. Elizabeth brought all the righteous fire that is so cool to hear in this room. But Davna was dropping truth bombs over here on the right side, and she did it in a very quiet way. And there's a point that she made that I think is really important to bring out for everybody in this room that has anything to do with the charitable food system. That is, right now, food as medicine is screen and refer one-way street, right? It's like the provider screen, send it to the charitable food system in the places where that's the model. But the food banks have been trying, and the partner agencies have been trying really hard to make things reimbursable. Like, that has been their huge goal for the last year, is to be like, how can we get paid for this work? That's really important. But they sometimes, I think y'all are underselling your power in this situation. the health system's asking you to help them lower their costs for their most expensive patients. And so please don't turn yourselves into pretzels trying to switch your way of being in the world just to chase those dollars. I mean, that's important. You need to get the dollars that you deserve. But the other thing is the reason that a lot of us in health were so excited about partnerships between healthcare and the charitable food system is that the charitable food system was the place where uninsured people were, where people that weren't eligible for Medicaid are, where people that don't have good access to care are. And don't forget that you have to take care of them as well. And like, I think those folks, like, they're going to get left out of food as medicine as currently construed unless y'all are able to talk for them. And I'm sure at Houston, I know y'all are so progressive and doing so much good work. Like, what are you doing on the ground right now to look out for those folks that are not going to be picked up by the current version of food as medicine?
Yeah, I'll speak about it as a national kind of network, and then I'll speak specifically in Houston. So, I think, thank you for that point, because I think that is absolutely correct, right? Chasing after dollars is not going to be the road that I think is going to be fruition for us. And so I think, COVID really amplified where food banks have opportunities. Disproportionately, we see where people were most impacted are the same areas that we have opportunities for greater access. And we've heard the model is built on quite a few organizations that are either faith-based, they're run primarily by volunteers, and we have an aging volunteer group that we don't really see kind of that next emerging strategy. So community-based or healthcare entities are great partners in those settings. What we are looking at, though, is that we are as a national network, trying to be much more strategic about how we think about our operation plans and where we placed services. And so putting people at the center of that work and calling out disproportionately communities of color where we have seen higher rates of this work, and what services are we providing. Houston specifically, we have a pretty aggressive model going forward. We used to have what I would say is very contractual agreements with organizations, and I think that was sometimes to our detriment. And so now as we think about bridging communities more closely, we don't want to talk about a contractual relationship. We want to say, how do we address this issue together as a community? And so it does mean making some difficult decisions. And so as I was sharing with some folks before, we're setting up a higher standard in terms of the amount of hours that a location is open. We're, evening hours or weekend hours where because the majority of our population is working, so they can be able to access services. For rural strategies, we're making a commitment to be there more frequently. Food banks operate on a very once a month method, and we know that the data shows that providing services once a month is not sufficient. And so we are rolling out those strategies with communities where it is not a top-down approach. It will take the next year working together. And it's really drawing upon those communities' feedback to us of where we need to be considering our core work moving forward.
Any other questions? I think we have time for maybe one more. Alice?
First, could you just explain what once a month strategy, what you mean by that?
So a lot of food pantries would be open once a month for maybe 2 hours in the month. And the caveat was everyone would go that one day and access services. Those models have not served communities well in many cases. And so we've kind of put forth some additional expectations around and really explained the why behind it.
And if I could sneak in one more question. Until the FDA figures out what's going on with use by, sell by, all those dates, how are you handling that respectfully so you don't feel like you're giving bad goods to people when it really is not bad goods and there's a lot of waste?
Yeah, our joint committee would tell you lots about that being a really big issue, right? That this idea of expired food and education around food. I would say we have doubled down in our nutrition work around food preservation. As more of the charitable food sector becomes perishable foods, And our quantities don't come in the same quantities that a grocery store comes. We have a responsibility to do a lot more in terms of how to store and prepare and preserve food. So we've doubled down on our nutrition education work. We've have a lot of different strategies that we employ to educate communities about that information. But if you ever want to volunteer at the Houston Food Bank, you will see that we take donated food as the highest respect of our food. We literally barcode scan every donated product that comes in. It is assigned a nutritional ranking. And we put a lot of intention behind how we treat donated food.
Do you accept soda, sugar-sweetened beverages?
We do not accept soda. I would say we still work with manufacturers, right? But we are also, what? I don't want to comment on that. I really don't know. That's probably, but what we do is we rank our food. And so we're transparent about the amount of food that we have that's nutritious and that's not nutritious, so that people can choose. The reality is if you go to a grocery store, there's all of these things set in front of you. We really value education and putting the emphasis on education to say, we're going to be transparent about what is nutritious in our food mix and what is not. And we work toward those goals to ensure that we are accepting more nutritious mix. And I would say we don't just do that with our partners, but we also do that with our donors.
I feel like in that aspect, there's also a lot of training for all of these partner agencies that have the pantries, not necessarily the food banks. So when you go online and you shop, you can, they're going to give you information on like low salt vegetables, and those are going to be generally 2 to 3 times more expensive for purchase than the other alternatives. And so when you have a church-based pantry that's trying to make their dollars stretch, they're going to make the choice to get the high salt alternative. For us personally, I remember going back and forth on canned tomatoes. There was a low salt version that was $15 a case, and there was another regular version that was $5 a case. And I'm trying to, make those grant dollars stretch, but I had to make the decision to go with the low salt because that's, at the end of the day, that's what we're trying to do. We're trying to affect the health of our patients. And so just those small little things, I'm educated and my team is educated enough to know that difference, but at a pantry level, and I know that our patients are shopping at these pantries because I give them a list and say, whenever you need to access food, here are some other places, because we can't feed everybody every day, but we can do our best to feed, once a month. Our food is medicine patients are weekly. And so making those kind of decisions and understanding the landscape that our patients are living in. So you have to live in their shoes, or just kind of really take into considerations the things that they're dealing with. So
That's a great place to wrap it up, Davna. Thank you. And a good reminder to, I'm thinking, funders and payers, whether they be insurance, philanthropy, federal dollars, healthy food costs more. And with grant dollars, you have an inclination to think when you're providing the grant, hoping, boy, I bet this will go really far. But what a great reminder of, food is medicine costs more. Thank you so much to our panel, all of you, especially our moderator.